Been promising pretty much since last week that we would talk about heart failure and right side versus left side and all of that stuff. And we'll also talk about dysrhythmias. These things can all be related to each other. So it all started with cardiovascular disease. Somebody developed atherosclerosis after a lifetime. And then maybe they had a myocardial infarction and part of their heart wall died, right? Uh, Now that part of their heart wall has died or part of their heart wall is insufficient for some reason, one of the many, many things we've seen today can lead to heart failure. Uh, Now they're in heart failure. Now, as healthcare practitioners, heart failure is going to be heart failure. Somebody with heart failure, as I understand it, treatment protocols are going to be pretty similar, whether it's right-sided or left-sided. Regardless of which side of the heart is failing, you're going to have congestion of blood flow backwards, and you're going to have insufficiency forwards. Your heart will not be able to maintain sufficient cardiac output. Myocardial infarction is a very common etiology. Now, to compensate for heart failure, your body's going to do a lot of things. Your body is going to try to increase your sympathetic nervous system activation to increase your heart rate and contractility. And that's going to help increase cardiac output. You're going to have RAS activation, renin, angiotensin, aldosterone system is going to help with fluid retention, which will help with preload. Remember, preload is how much blood flows into your heart from the system, and that is going to impact your cardiac output. And you're also going to have hypertrophy of the heart during heart failure. So all of these are in an attempt to increase cardiac output. But remember, the heart wall itself is insufficient. The problem is in the heart wall. So hypertrophy causes its own problems. Having sympathetic nervous system causes its own problems. Having fluid retention has its own problems. So you're going to have forward failure, insufficient cardiac pumping, and you're going to have backward failure, congestion of blood behind the chamber. That's problematic. Now, your textbook has some amazing pictures for this, and by amazing, I actually mean terrible. These are the pictures from your textbook. They're down here in the corner. I'm not sure what you're supposed to be getting out of those pictures, aside from there's a naked lady on a bench. So I went to an outside source and I found, I think, much better visuals for what your sided heart failures look like. Now, again, take out your worksheet from last week with the different sides of the hearts and the arrows and take a look at what left-sided heart failure is going to look like. You're going to have problems upstream. The backwards effects are that blood is congested in the body. Fluid is congested in the body. Oh my gosh, I just did that completely backwards. I'm sorry, guys. Fluid is congested in the lungs because we're talking about the left side of the heart. Hopefully you guys were listening and you're like, wait, no, Reeves, you're saying it wrong. I really hope you were telling me I was wrong at home. So left side of the heart takes blood from your lungs to your body. So the problem with left-sided heart failure is congestion of fluid in your lungs and insufficiency of blood being pumped forward. So most of the manifestations are pulmonary congestion. You're going to hear cough and crackles and wheezes in the lungs. And then again, the forward effect, the downstream effect, are going to be like cyanosis. Their lips are going to be blue. Their fingers, their feet are going to be blue. They're going to be fatigued. There's going to be tachycardia. Again, remember, that's our compensatory mechanism. We're trying to increase cardiac output with an increased heart rate and contractility and preload and a more powerful heart wall, right? So all of these clinical manifestations are a product of the left-sided heart not being able to pump forward. So stuff gets stuck behind and forward is insufficient. Now let's go through this really quick. Left ventricular failure, forward effects, decreased cardiac output, and decreased tissue perfusion. That's going to be a really big clinical manifestation. Backwards effects being, again, just fluid stuck behind the left side of the heart in the lungs. Now, right-sided heart failure, the right side of the heart takes blood from the body and sends it to the brain, or to the lungs rather, sorry. From the body to the lungs, from the body to the lungs. So right-sided heart failure, you're going to see fluid buildup in the body. They're going to have really big swollen ankles. They're going to have a distended jugular vein. You may even be able to see that jugular vein from across the room. And even if you can't, there's actually some really cool, there's some cool things you can do to make their jugular vein pop out. Ask a clinician next time you see a heart failure patient if you can see them have their jugular pop out. It's really cool. So ascites means fluid in the abdominal cavity as well. So I think that's what these women are trying to convey is sort of the fluid in her abdomen, the fluid in her legs compared to she's having respiratory distress. I don't think it's really great at illustrating either of those things. I think this lady's better for it. Ascites, enlargement of the liver of spleen. Again, this is just about fluid backing up in the system. Meanwhile, blood is not going to the lungs. So fatigue, activities are limited, congested heart or chest congestion, edema or ankle swelling, shortness of breath. FACES is our acronym for heart failure. Now we can improve cardiac output with certain drugs like digitalis. We can inhibit the sympathetic nervous system with beta blockers. We can improve contractility with a variety of drugs. We can decrease the RAS pathway with ACE inhibitors. And we can also use pacemakers. One concern here is going to be dysrhythmias developing as well. But once the heart is failing, we can't bring those cardiomyocytes back. So this does tend to be degenerative, this does tend to progress, and this does tend to eventually be lethal. Now again, that could take years in some cases. My grandmother's 93, she's still kicking around. She's had heart failure for a while now. I don't know how she's walking, but she is. So okay, let's move on to cardiac dysrhythmias. Now, we're going to see the mechanisms of cardiac dysrhythmia, and we're going to see that having a blockage of the heart, maybe a patch of dead cardiomyocytes, can be one of the mechanisms that leads to a cardiac dysrhythmia. Why am I telling you this? Because on your worksheet today, I'm going to have you put some stuff in order. Let's say somebody has all of these things over their lifespan. Over their entire lifespan, they've developed all of these problems. There's going to be a certain order these are going to happen, and a dysrhythmia can only happen, for example, after a heart block. I will clarify on this worksheet, thrombus formation, I'm going to consider this like atheromatous plaque formation. This is the multi-decades, we developed some plaque in the arteries. This isn't a sudden thrombus formation. That was the issue last quarter when I introduced this. Do we mean a sudden thrombus formation? Do they suddenly throw a clot? No, this is the atherosclerotic plaque development. So this is going to have to be pretty early on in this system. But one person can develop all of these, and if they do so, it's going to happen in a specific order, and that's what I want you to put on this timeline down here. I want you to have little lines and say, okay, this is the first thing to happen, this is the last thing to happen, this is the manifestation that happens because of that. I want you to understand cause and effect here. Now he's from Living Arrhythmias. He's a video. I probably don't want to embed that video into my video because it's somebody else's video. But at a certain point, the best thing you can do to understand dysrhythmias is watch the Living Arrhythmias video. It's wonderful. So dysrhythmias are the same thing as arrhythmias. It just means that instead of PQRST on your ECG, instead of your atria contract and then your ventricles contract. Things happen too fast or too slow or in a discoordinated fashion. Maybe your atria contracts multiple times before your ventricles can contract. They indicate something is going on. There's an underlying pathologic disorder. This isn't the first thing to happen. This might be something that happens much later, after part of your heart wall has died, for example. There's a second video I really, really want you to watch. It's Reentry Circuits Explained with Roads. Sometimes this link works, sometimes it doesn't. Again, it's somebody else's video. I'm not going to play it for you here in my video because it belongs to somebody else. I don't think this is it. Nope, this is definitely not it. This is it over here. So UBM faculty or UBC Faculty of Medicine. Yeah, this is the video you want to be watching. Reentry Circuits Explained with Roads. He does such a good job. He does a better job than I'm ever going to be able to do. So I will kind of tell you when the best time to watch that video is. A reentry circuit means at some point there was a premature beat. Now, in order to understand this, we got to go back to that electrical impulse traveling through the heart. Now we have an SA node, we have an AV node, we have a bundle, AV bundle or bundle of his if you're old school, and then that bundle branches and you have bundle branches, and then at the apex of the heart, those fibers crawl back up the heart wall, and then we call them Purkinje fibers. So that's how we propagate action potentials across a heart. So far so good, right? So you have action potentials going through this pathway in your heart. Now we kind of illustrated it like it's just one pathway, like there's just, one single line through these cardiomyocytes, the way they're connected. That's not quite accurate. There's actually multiple pathways, and in particular, there's a fast pathway and a slow pathway that we've just never talked about. Now in this video that I'm going to have you watch, the really good one where we have a metaphor for it, he's going to talk about action potentials as though they are cars, and then these pathways are going to be like the road they're on. And he's going to set up some rules. And so the rules he sets up, when an action potential meets a fork in the road, so an action potential is traveling in this direction, it meets a fork in the road, it's going to split, and there's going to be two action potentials. One on this pathway and one on this pathway. And in a working heart, in a properly working heart, this action potential on the slow pathway is going to run into this action potential from the fast pathway, and it's just going to stop. That's the second rule. When two action potentials meet, they stop. Now notice, this was one action potential, it divided into two. And then there was another fork in the road, so that first action potential on the fast pathway, it just split into two again. So we started with one action potential. In a normal sinus rhythm, you end with one action potential going through these two pathways. If that didn't make sense, I recommend pause and rewinding it. There's not really a better way for me to explain it than that. Those are the two rules. An action potential splits at a fork in the road, and when an action potential meets another action potential, they negate each other and they stop. Okay, for a reentry circuit. A reentry circuit is one of our mechanisms of a dysrhythmia. In a reentry circuit, there is a premature beat. I don't have a really good image for this. It's really hard to find one. Okay, in a premature beat, you have the action potential coming in, you have the initial fork in the road, but the timing is wrong for the slow and the fast pathway. And because the timing is wrong, instead of having this cancellation here at the correct place, there's no cancellation. And what you're going to end up with is an action potential that continues around the fast and slow pathways in a circle eternally. It's just going to keep going, and every time it meets this fork in the road, it's going to split. And every time it meets this fork in the road, it's going to split, and it's going to keep sending action potentials forward through the conducting pathways of the heart. If this sounds really confusing, it's because it is. I have been teaching it for years now, and it still is difficult for me to understand. I think this video is the best thing you can possibly understand or possibly watch to understand it, more so than any understanding I could give you. So go watch Reentry Circuits Cardiology podcast number 2 from UBC Medicine Educational Media. It is a lifesaver. So you're going to want to watch that a couple of times. I recommend stopping this right now and going and doing that and then coming back. So now that presumably you've gone and watched that video and you say, oh, okay, I understand the fast circuit and the slow circuit and the rules of why they're fast and why they're slow and why cars will get stopped here and they'll slow down here and they'll get derailed there. And again, those cars are just action potentials. We're just setting up the rules for what action potentials do and how just a premature beat can lead to tachycardia, basically. So another mechanism that can start reentry aside from a premature beat is also a block. So a block in the heart, so maybe myocardial infarction, for example, means that instead of that circuit going in a perfect circle, it's going to start a reentry circuit. And once again, the pace of the heart is going to be determined by the improper action potential instead of the properly generated action potential from the SA node. So there's a variety of different kinds of blocks. These blocks are all sort of the same idea where part of your save as bundles Purkinje system is defective. Maybe there's a myocardial infarction and it's broken down, or some other thing that is going to mean electrical conduction is inhibited in some way. So there's 3 types of blocks. It exists on a continuum, so we categorize it into 3. A first-degree block is going to be pretty minor and usually no treatment will be required. But once you get to second and third-degree blocks, you have little communication between the atria and the ventricles. Remember, it's supposed to be atria contract and then ventricles contract. And never the two shall happen at the same time. That would be bad, right? So this is the point where you want to go watch the Dysrhythmias video. The Living Arrhythmias video is absolutely wonderful. We did watch this in AMP2, Living Arrhythmias with soundtrack, just to give you the visual of what you're looking for. I'm not going to show you the whole video. It belongs to this guy, not to me. Now that you understand the mechanisms of a heart block and the mechanisms of a pre-entry or a re-entry circuit, this video is suddenly going to make a lot more sense. It actually happens every single quarter. Even more so if you have an emergency medicine background, suddenly everything's going to click into place. So with these different degrees of blocks, what you're going to end up getting is discoordination between atrial contraction and ventricular contraction. If you haven't already paused this video to go watch Living Arrhythmias, do that now, and then come back to me for this next part. So now you have discoordination between atria and ventricles. When you get to, say, some of these heart blocks, one possibility is that the atria contract multiple times before the ventricles contract. That's one of the dances that he does in the Living Arrhythmias video, is he does multiple atrial contractions. He's waving his arms multiple times before the ventricular contraction, which is when he bends his knees, right? That is exactly what it sounds like. It just means that that atrial contraction that was caused by SA node stimulation did not communicate through the AV node to the ventricles. There's a block. It's very literal. So atrial fibrillation can lead to atrial flutter leads to atrial fibrillation. And fibrillation is completely disorganized. Now, I'm not teaching you everything about the ECG, Karen Riley does a unit for ECG later, and she does a great job with it. She goes into much more detail. What I have heard and learned from clinicians is that when you, as nurses, are looking at an ECG strip, you're not going to be sitting there saying, that's multiple T waves, that's multiple P waves, that's multiple QRS complexes. Let's go over here for just a second and say abnormal ECG patterns. So you may not be able to say which of these is a P or a Q or a QRS or a T, right? You're just going to see frequency and you're going to see amplitude and you're going to see that there's something wrong. What I'm doing here today is saying, if you know that it's atrial flutter and you know that the P wave marks atrial contraction, then in this case, reverse engineering it, you know this is multiple P waves. Hopefully that statement made sense of what we're differentiating here. Again, we're reverse engineering it. We know that P is about atrial contraction. And we know that this person's an atrial flutter. So you can connect those ideas in this class, but those ideas may not transfer to the real world. So atrial flutter and fibrillation, you're going to see problems with the P waves. Again, if you're looking at a strip, that may not be the obvious thing. There used to be a lot more slides. In your textbook, there are many, many more slides associated with abnormal ECG patterns. So all I want to convey and all I would test you on would be what we've actually covered. You know P waves would be about atrial problems. You know a QRS problem would be about ventricular problems. And that's really as far as we're going with it. We also saw some patterns associated with myocardial infarction and ECG. We saw STEMIs, elevated ST segments, associated with myocardial infarction, and also T waves associated with myocardial infarction. But that's it, full stop. I am not an ECG expert. Karen Riley is, so I'm going to have her teach you that instead. And that's it, that wraps it up. Let me know if you have any questions, any points of confusion. There is a lot today. Go back over the Living Arrhythmias video. Go back over the metaphor of roads for reentry circuits, because it is the best explanation I've ever seen for reentry circuits. And start thinking critically about how to put this on a timeline. Remember, thrombus formation is, we're talking about atherosclerotic plaque. In fact, I'm going to change it, atherosclerotic plaque. And I'll upload this one. Let's go over the rest of this worksheet before I turn you away. Remember that the events of inflammation, you are combining multiple slides here. This is something you have to synthesize, not something you're just rote copying. You're going to define each of the following as it pertains to the development of atherosclerotic plaque. So you have a pretty beneficial vocab list right here. Oh, down here is the nature of vulnerable plaques versus the nature of stable plaques. That's pretty straightforward. I think all of this is pretty good. This is, again, a timeline. You'll illustrate, you'll use like a dash, and you'll put whatever you think came first in this person's medical history. Assume this is one person who just gets everything. And again, these things are related to each other. That's why today is built the way it is because these things are all related. They don't happen in a vacuum. You don't get angina without atherosclerotic plaque development. You don't get a cardiomyopathy without a myocardial infarction. And then I'm pretty happy that this is fill in the blank. So reentry circuits. Watch that video while you do this one. Watch the reentry circuits video while you fill this out. They occur because of two pathways within the heart. When one pathway splits in two, action potentials will do what? When action potentials meet each other, they will do what? In a normal circuit, the heart rate is determined, typo, by the two divisions of the blank nervous system. The autorhythmic cells, which usually initiate the heart contraction, also known as the pacemaker of the heart, is known as the what node. I think even from my lecture, you should be able to get most of this, but in case you have any questions, you are more than welcome to email me. Otherwise, set up office hours and let me know if you have any questions. Thank you so much for your time and attention. And again, I'm sorry this snow day is so problematic for us.